day off work, and we need to get the treatment done today. Pediatrics is difficult because we're not only dealing with the child, we're also dealing with the parents and the grandparents and the aunties and the uncles sometimes. So why is it so important? The World Health Organization recommends a continuum of care to safeguard and maximize children's developmental outcomes. Children with dental disease suffer from poor nutrition, failure to thrive, chronic pain which affects their behavior, sleep, and performance at school. And we're all aware that dental caries is the most prevalent disease affecting children. And 99% of dental disease is preventable. So the learning outcomes for today will be the challenges that we face, understanding a little bit more about minimal intervention dentistry, updating our knowledge about dental caries. We'll talk about some core principles of MIPD. We'll talk about minimally invasive management options and materials, and then finally we'll summarize. So one of the biggest challenges that we face is a paradigm shift from the narrow focus of mechanistic, cavity-orientated surgical approach to embracing new strategies in caries prevention and management, and understanding the difference between the carious process and the carious lesion. Sorry about that. The current COVID-19 pandemic has massively affected our ability to care for our patients, and we will need to adopt new practices and protocols going forward. The future, unfortunately, is unclear. The other challenge that we face is remuneration within the current financial model. This is the problem because we are treatment-driven and not health-driven. Unfortunately, I don't have the solution to this one yet. So what is minimal intervention dentistry? It is a holistic, patient-centered, risk-based philosophy that prioritizes prevention, early detection, and non-invasive or micro or minimally invasive treatment modalities. So let's talk a little bit about the science of dental caries. We all know that the microbiota within the oral cavity consists of several thousand species that live within an ecosystem. The metabolic process within this ecosystem is highly dynamic, and under normal circumstances, there is a balance between de- and remineralization. Ecological disruption, is essentially an acid-induced adaptation and selection process where more acidic bacteria become dominant. We now refer to this as the ecological plaque hypothesis of the dysbiotic plaque biofilm. Dental caries is essentially a lifestyle-related non-communicable disease. And it is very important for our patients to understand this because going forward, they will have a large part to play. So essentially, this is what we are talking about, a balance between demineralization, which occurs when we have too much plaque bacteria, and a diet rich in refined carbohydrates, against remineralization, which occurs due to the clearing and buffering capacity of saliva, effective oral hygiene practices, including brushing and flossing, and the all-important fluoride. So how do we apply this knowledge? This is a flowchart of the core principles that we need to consider. We'll start with recognition. This is about diagnosing the lesion under the ideal circumstances of having a dry, clean field. Good lighting and magnification is ideal. However, it is also an in-depth oral health assessment about the main contributing lifestyle factors, including diet and oral hygiene, and social and medical history. Sometimes caries risk assessment tools can be helpful here, like Canberra and Karyogram, and I would suggest you look into these in a little bit more detail because they are methodically highlight risk factors and can be changed. Remember, children are dependent on adults for their healthcare needs. And sometimes we need to be aware that there may be a network of care giving with varying levels of involvement. For example, we may have a child attend with the parent and give them all the oral hygiene instructions, but at home, it's actually the nanny who looks after the children. So we really need to ask the right questions. Getting caregivers to accept their responsibility is fundamental, and understanding and discussing barriers is also important. The main areas to explore are knowledge about brushing, when, how, fluoride levels, whether we should spit out and not rinse, and skill, which can identify problems with technique. Anxiety levels and attitudes towards
especially overwhelmed by the cleanliness and the quality of children and the baby.
Building rapport with children is really helpful too. And there are many ways that we can use, like giving children control, distraction, tell, show, do, to name a few. However, it is important to remember that we are dealing with children and not adults. So we need to be a little bit more patient and understanding. Sometimes no treatment is not a failure. It is all part of the process. As discussed above, caries is a dynamic process. So we need to consider varying aspects of the lesion, including stage, activity, and the likelihood of it causing symptoms. This is how we can justifiably make informed decisions about our care plan and assess whether it is successful or not. Then we move on to reorientation. This is about how we use that information gained during the recognition process. We need to remember our role is not to change someone's behavior. It should ideally be to support behavior change where that's possible. Evidence-based practice tells us that simply telling the patient what to do doesn't work in the majority of cases, and we tend to waste our time and the patient's time. The models that do help are motivational interviewing and coaching. And the pertinent aspects of these are capability, opportunity, and motivation to change. And only then can we go into the goal setting, planning, and self-monitoring. Remineralization will occur when we tip the balance with effective toothbrushing, use of fluoride toothpaste, and reducing the frequency of dietary sugars. And it is important to note that even with more invasive dentistry, the longevity of restorations depends on the environment, and this is key to successful outcome. Repair can be complicated with children, and we need to consider many factors before we can make a care plan. So moving away from thinking that caries is like gangrene and we need to aim to get rid of it all, let's start thinking about caries as a process. The traditional drill and fill does not address the big picture. Nowadays, it is becoming more important to justify our decisions for medico-legal purposes. Therefore, noting the activity and stage of the lesion is important. And we can use tools like the International Caries Detection, Assessment and Classification System, ICDA-AS, or simply grade the lesion as initial, moderate, or advanced. The review element is also important and should not be ignored. Recall intervals should be adapted to caries risk and updated accordingly. Seeing a low-risk patient every 3 months and seeing a high-risk patient every 2 years defeats the purpose of this fundamental part of the process. We need to assess whether patients are adhering to the advice and the recommendation. We can detect subtle changes early, and we can act upon them if necessary with minimally invasive procedures. And this gives us the opportunity to tweak and reinforce our oral health advice. So let's start at the beginning. Sadly, patients don't always see what we see. I am brushing every day, Daktari, but when you use disclosing gels and tablets, that highlights the plaque biofilm. We've already started the process. We obviously can't be responsible for brushing patients' teeth on a daily basis. And so if we don't educate and demonstrate and encourage and point them in the right direction, we'll be trying to win a losing battle. This is the key to successful outcomes, and it cannot be overemphasized. GC has a very clever and colorful disclosing gel that can be used in the clinic, which I've put a photo of down here. But patients can also buy disclosing products over the counter to use at home. So now let's talk a little bit more about the practical aspects of MIPD, starting with the most conservative, which is non-restorative cavity control, using 5% sodium fluoride varnish. Now, this is a progressive approach to caries lesion management, which seeks to inactivate and arrest lesions. The indications are early enamel demineralization, white spot lesions. The lesion must be easily accessible, non-retentive. We can use this with young children. And the caregiver must be willing and able to help with plaque biofilm control and decrease in the sugar intake. Parents also need to understand that this procedure needs to be repeated and monitored periodically. So this is an example of a 10-month-old child who presents with extensive enamel demineralization, caries extending into the dentine, and plaque stagnation. These lesions were judged to be potentially cleanable, and the parents were very keen on a minimally invasive approach. The treatment protocol was clean the surface of the teeth, apply 5% sodium fluoride varnish every 3 to 6 months. And I'm sure you will agree with me that these results are stunning, primarily down to biofilm and diet control. Non-cleanable lesions can be minimally adjusted with hand and rotary instruments to remove undermined enamel, making the lesion amenable to effective oral hygiene and fluoride varnish application. So on the left-hand side, you can see a bunch of pictures where there's been an adjustment made to the proximal surfaces of the lower incisors, making it so much easier to clean and for the fluoride varnish to retain. And the same thing on the right-hand side. It can be a Sorry, I keep getting unmuted, so just bear with me. So now we move on to non-restorative caries control using 38% silver diamine fluoride. This is something that has recently come into the news. SDF is composed of silver that has an antimicrobial function and inhibits the biofilm formation, fluoride ions, which promote remineralization, and ammonia that stabilizes the solution. Essentially, SDF reacts with dentine protein and lays down a layer of silver protein that is resistant to bacterial acid and promotes the formation of hydroxyapatite and fluoroapatite, increasing the hardness of the treated surface. Sometimes referred to as the silver bullet, SDF is an invaluable and predictable tool. It can be used alone or in conjunction with restorative procedures. And the great thing about it is it's just a clear liquid, requires minimal tooth preparation, and therefore is really easily acceptable by young patients. The only drawback is that SDF does discolor the lesion, and therefore informed consent from patients is important. The indications for SDF are enamel or dentine caries with no signs and symptoms of pulpal involvement. It can be a multi-surface lesion, and it's really great for children who have limited access to dental care because it really is a very predictable option. So here you can see an example of a patient I treated a few years ago. This is just one application of SDF, and you can see the remarkable discoloration. And if you feel the dentine, it feels hard. In this case, because of the extent of cavitation, this patient was also quite high risk and he was young. I did end up putting a crown on the tooth, but at least I was assured that the caries activity had arrested. Now, when dealing with children, and it's very important that you have everything ready and that your assistant is well versed with the procedure. So the treatment protocol is essentially make sure you apply Vaseline to the lips and the perioral regions because the SDF does stain. Isolate the tooth with cotton wool rolls. Dry the tooth with a cotton wool pellet or gauze. And remember, this is a non-aerosol generating procedure. Dip the microbrush in the SDF solution and scrub the lesion for 1 to 3 minutes. I would recommend using a timer, just makes it easier. Now, another thing about SDF is it doesn't taste very nice. So what I usually do is apply a little bit of fluoride varnish over the lesion once I'm done, which just helps with that situation. A really interesting technique to modify the SDF is when we have a situation like the radiograph on the lower left-hand side, where you can see very early decay between the E and the D. Now, if we were to restore this tooth conventionally, it would end up being quite destructive. But what you can actually do is isolate the area, dry the tooth, put a little bit of SDF on some superfloss, and floss through the lesion for 1 to 3 minutes. It is important to take periodic x-rays so that you're monitoring the lesion, but this is a 1-year follow-up and you can see there's been absolutely no change. So it's a really handy technique. SDF can be further modified to silver modified atraumatic restorative treatment, also known as SMART. This is where you apply SDF to the cavity and then you restore the cavity with a high viscosity glass ionomer. So in this case, I very minimally prepared some of the enamel so that I could get a little bit better access into the carious lesion, applied the SDF, and then after 2 weeks saw the patient. Very, very minimal cavity preparation just with hand instruments, and applied a high viscosity glass ionomer. And you can actually see that there's a little bit of discoloration around the cavity from the SDF. Again, this patient, I saw him a couple of years ago and I reviewed him this week. The cavity, the tooth looks exactly the same. And remember, he is a high-risk patient. So it is a very, very good predictable option. So now let's move on to caries control. And let's start with sealing in caries tissue with glass ionomer. Now, the rationale behind this is by depriving the microbiota from dietary sugars, we're challenging their pathogenicity, and we slow down or arrest the progression of the carious lesion. The dentine pulp complex produces reactionary dentine, and tubular sclerosis occurs, which further isolates cariogenic bacteria from the pulp. Glass ionomer, due to its fluoride release, the chemical bond that it forms, the hydrophilic nature, and the ease of application, is the ideal material for this technique. The indications are for non-cavitated occlusal lesions, or it can be used for non-occlusal lesions, for example, buccal pits. We can discuss fissure sealants with glass ionomer and resin cements here because they're applicable. The only difference would be the adhesion and the relevant protocols. The reason I've put up this photo is not really because of that distal cavity, but more because of the fissure sealant on that mesial fissure. So the treatment protocol is, again, very simple. Isolate the tooth, and you can do this with a gauze, again, non-aerosol generating. Apply a high viscosity glass ionomer, and then ideally with a water-based lubricant on a gelled finger, apply gentle pressure on the tooth. And once the cement has set, you can use a hand instrument to clear any overhangs or adjust the occlusion. So now let's move on to one of my favorites, the whole crown. The whole crown technique is essentially an extension of sealing in caries, but in this case, we're using a preformed metal crown and a glass ionomer luting cement. The indications are small to moderate carious lesions, including the aproximal lesions, hypoplastic teeth, and where there is no indication of pulpal involvement or after pulp therapy. The contraindication for whole crowns is if we have a patient who has systemic problems, for example, if the patient has a risk of endocarditis. So essentially, whole crowns require none or minimal caries removal and crown preparation. And in many cases, we don't even need to use local anesthetic. Preparation is really important. Show patients what the crown will look like, because some patients or parents don't like the appearance of metal, and explain the procedure before you start. For the patients, make it exciting. Tell them that they're going to be a new prince or a princess and that they can show off their shiny helmet and twinkly tooth to their friends. And that really helps get them on your side. So how effective are whole crowns? Now, there's a lot of research that's gone into this. And this is one study that was carried out in Scotland by 9 GDPs It was a split mouth randomized controlled design. And the following are the results. And you can see very clearly that the whole crown showed remarkably less major and minor failures in comparison to conventional restorations. How acceptable is the whole crown? Again, same study, looked at the acceptability for the child, for the parents and caregivers, and the dentist. And again, the whole crown came up much, much better than conventional restorations. So let's talk about how to fit the crown. Essentially, the crown will come in a kit with different sizes, and I would advise getting the whole kit because it's very, very difficult to predict what size you're going to have. The first thing you need to do is assess the shape and size that you're going to need. It is really, really important to protect the airway because they're very slippery. Now, getting the right size does take a little bit of practice, but what we're aiming for is what we call a snap fit. Once you've found the right size, you come to ask your dental assistant to load the complete crown with diluting cement, and then you fit the crown over the tooth and ask the patient to bite on a cotton wool roll. Sometimes at this point, the patient might complain a little bit, so just try and distract them, just talk to them or show them something, but just make sure that they apply this constant pressure. And once the cement starts to set, you can remove any excess cement and assess the fit. Sometimes we run into a situation where the contacts are a little bit tight and we can't easily just fit the crown over. So for this, a really good trick would be to floss through some orthodontic separators and leave them in situ for about 3 to 4 days. And usually once they're back and when they're removed, there is enough clearance for you to be able to put the crown on. Occlusion very rarely needs to be adjusted. And because of the minimal preparation, the crowns are going to be a little bit high. So I usually just reassure the patient and tell them that it's going to settle in the next 2 to 3 days, and it usually does. It is important to floss through the contacts so that you don't get any cement in between. And post-operative radiographs are recommended. I want you to just look at the second picture on the right-hand side, and you can notice this classic blanching that you get on the gingivae. And that's classic for a good indication for a good fit. So now let's talk about selective caries removal. This is a concept that is becoming more and more important. When we are discussing adhesive dentistry, we need to consider 3 things: the histopathology of the lesion, the biochemistry of the restorative material that we're going to use, and operator factors. What works well in my hands? What resources do I have? And if we can juggle these 3 aspects well, then we can start to place optimal biointeractive adhesive restorations. Now, looking at this cross section through the tooth, we need to start to appreciate that there are 2 distinct histological zones within the lesion. We have the outer zone, which is a highly demineralized area where the collagen is completely denatured. It's highly bacterially infected and contaminated, and this is not remineralizable. However, if you go a little bit deeper, we go into the inner zone, which is, yes, demineralized, but there is less bacteria. The collagen fibers are still intact. And what's most important is that this zone is still remineralizable. Now, the difficulty is that these zones are not distinct, but it is important to appreciate the capacity to heal tissue under the correct circumstances, especially when we're discussing pediatric dentistry, because we know that pulp therapy has its limitations, and therefore we should aim to consciously prevent exposure and allow remineralization to occur. The discovery and research around bioactive materials, which by a number of chemical, mechanical, physiological, and sometimes even genetic pathways can actually heal the tissue. One of these materials is Biodentine, which is developed by Septodont. This is a tricalcium silicate-based cement which can be used as a dentine substitute and is very useful when treating deep carious lesions, pulp capping, and even trauma. We don't have enough time to discuss this, but it is worth looking into. One really interesting thing I wanted to show you is on the left-hand side, you can see this microscopic image, and you can actually see the impressive tags that the Biodentine has formed within the dentine. And I think this is really amazing. Another novel revolutionary approach to treatment of incipient caries is resin infiltration. This is a breakthrough microinvasive technology that fills and reinforces demineralized enamel without any drilling or anesthetic. It essentially involves removing the mineralized layer of enamel with hydrochloric acid and allowing a low viscosity resin with similar refractive index to enamel to infiltrate the porous hypomineralized white lesions. This can be really helpful with mild fluorosis, which we do see in Kenya. It can also be used to treat proximal lesions with a specifically designed system, but I think you can also look into that a little bit more. So finally, dental clinics invariably carry a risk of COVID infection due to the face-to-face communication with patients and exposure to blood, saliva, and other body fluids. We carry out aerosol generating procedures, which allows the virus to remain suspended for long periods of time. We therefore have to think out of the box and devise new ways in which we can help our patients. We have never really been able to drill our way out of a behavior-driven biofilm disease. So let's consider the MI philosophy. We have the evidence for it. And patients may have less access to dental care. Therefore, we need to give them the right information, and prevention advice is going to be extremely important. Finally, with all the additional PPE, coming to the dentist is going to be that much more daunting for our pediatric patients. So I'd like to refer you to the British Society of Paediatric Dentistry website, where they have some really useful resources on how we can prepare our patients better. So I really hope this presentation has been informative and has successfully shifted the paradigm on how we can care about our patients. Thank you so much for listening.
Thank you, Dr. Aisha, for your lovely presentation. We encourage, if anyone has any questions, to kindly jot them down in the question and answer session. So far, we have 4. We thank you as well for participating in our first webinar and staying online. So we'll go to the first question. Dr. Aisha, Dr. Ireri had commented, I think she was reacting to a statement you made, that dentists are usually more treatment driven as opposed to health driven. Would you like to expound on that?
Yeah, so I think what I was referring to is the remuneration system, because if you look at how we're paid, we get paid for doing a filling or doing a root canal, taking a tooth out. We don't necessarily get paid for spending time with the patient on prevention protocols. And I think that is a global problem. I'm not really sure how to fix it, but I think a lot of times it will need to come from us. You know, we need to see that this is important and it's vital to long-term success, and it's important for success for any operative procedure that we do. So I think it is a challenge, but yeah, I don't know. I don't know what the solution is.
So more emphasis on treating the patient as a whole.
Exactly.
So maybe sometimes maybe we're trying to clear the queue. Is that something that you've experienced locally and internationally? Do you want to see the patient and do that filling and maybe get rid of the patient until the next patient comes in?
I think it's one of those things where it's a different attitude towards dentistry. For some dentists, it is about just getting the treatment done. But for some, they see the importance of prevention. And I think looking at the evidence, it really is vital because, you know, we've been doing the drilling and the filling, and you still have patients coming in with problems. So I just don't think that sometimes we're addressing the problem effectively. And so we need to make an extra effort to change how the patient's thinking. Yeah, to think about the patient, not just the cavity.
Okay. We had a question from Dr. Purvi. She was asking, in terms of your GIC, would you prefer using chemical cure or light cure?
So I think with children, it really depends. I use whatever I have access to. I know that there is evidence that promotes the resin modified glass enamel, which is light cured, and it just makes it easier because it's quicker. But sometimes I think you need a little bit of both. So it really depends on the situation, I think.
Okay. What about kids who are in cooperative? Is there an advantage maybe of the chemical cure?
Yes. Actually, I think children who are uncooperative, the light cure is better because it's just a bit quicker. You don't have to wait too long for it to set. So I think, in my opinion, the light cured would be better for uncooperative children because it's just quicker.
Okay. There's a question with regards to the whole technique. I think with regards to the stainless steel crown, they're asking, there's a question that is there a need to adjust? Maybe it's asking about, are you worried about a high contact or even the blanching? You had mentioned that blanching is a sign of a good fit. Is that something you need to be worried about?
In my experience, I very rarely need to adjust the stainless steel crowns for primary teeth. Sometimes you will get the odd shaped tooth, and so yes, you will need to crimp it a little bit. Sometimes you may even need to minimally prepare the tooth. A good trick that one of my mentors, Dr. Purvi, actually shared with me was that if you have a lower right, so this tends to happen a lot with Ds. So if you have a lower right D, you can try and use the upper left D, and that sometimes works. But I very, very rarely will adjust the crown. In terms of the occlusion, because it's minimally invasive and you're not doing any preparation on the occlusal aspect, it is high. And you're expecting that. But I just warn the patient and I tell them that it is going to be high, just have a soft diet, maybe a painkiller if they need it, but it tends to settle down. I've never had a patient come back because the stainless steel crown was high.
Okay. Another question is Icon readily available in Kenya? That's
a really good question. I think it is, but I haven't managed to get a hold of it. I've only been using samples of it, and even that I haven't used it as much. But I think the company is DMG, and I do know that they have an Africa sector. So I'm pretty sure. Dr. Amin says Trans-Africa has it.
Okay. I think the other question is I think the question was between topical fluoride and SDF, which is better?
I would say SDF is probably a lot more effective. The only problem you have sometimes is patients don't like the discoloration, especially if you're gonna use it in the anterior region. So yeah, SDF is more effective, but if patients are not going to let you do it because of the discoloration, then you can use fluoride varnish.
Okay, and what usually happens if you get staining on the skin, maybe on the mucosa, the lips?
So that's very, very common. In fact, I have some on my finger right now from using it a couple of days ago. You just, first of all, take the precautions. So make sure you're putting the Vaseline over all the areas. And if it does happen, just reassure the patients. It just forms a bit of a small tattoo, and it tends to disappear depending on how quickly the cells will regenerate. So it'll just take a few days to go away. Yeah, but it's not a big problem. But you do really need to be careful because it gets everywhere.
Okay. Someone had asked, how do you know that you have SDF on the floss when you're trying to apply it interdentally?
So that's a really good question.
Mm-hmm.
Yeah, because it's a clear liquid, so it's that's a really good question. So what I tend to do is I just make like a little inch to 1.5 inches, and I draw. I mark it, so with a pen or with a pencil, and then I know that I've put my SDF in that space. So it's much easier to know where you've put the SDF, because it can, even that is, you can sometimes get lines of SDF on the child if it goes all over. That's not ideal.
Okay, again, with regards to Hall's technique, the question is, does the patient need an analgesic post-op for maybe 2 to 3 days, or usually kids respond very well?
I think that's a subjective one, because some patients are okay, but I do warn the parents, and I just say that if the child is complaining, then yes, give them an analgesic. But yeah, I've never had a patient call up with post-operative pain. Yeah, I've never had any complications with that.
Okay. Is GIC, do you prefer GIC over composite?
I do, question. Yes. It really depends on the situation, I think. A lot of times with children, moisture isolation can be difficult. And so I like using GIC, and I find in my hands it works. Of course, not in a very large restoration, but you know, if you get the right conditions, then it does work really well. And I feel a little bit reassured with the bioactive nature of GIC in comparison to composite. And a lot of times when I have seen patients coming in with failure, it's usually a catastrophic failure when it's under a composite. But if you have a GIC that's failed, I find I really have a lot of caries underneath. Whereas with composite, there's a lot of caries underneath. So that's just my personal experience.
Okay. Is there any supporting evidence to use concepsis in deciduous teeth before SDF or Biodentine?
Sorry, I didn't get that question.
They're asking if there's any supporting evidence for the use of concepsis in deciduous teeth before SDF or Biodentine.
What's concepsis?
I don't know whether it's a material, but it's from an anonymous attendee. Could you kindly re-ask the question? Then we can get back to that. The next question, someone is asking, for your contact or your email ID or number for further collaboration. You can get in touch with the association and we can link you up with Dr. Aisha.
Yeah, that's fine.
The next question is, does air abrasion have a place in minimal invasive dentistry?
Absolutely, and it's extremely important when we're talking about adhesive dentistry. Difficulty is that I have tried the machines in the UK, but I don't know that they're available here, and they're also quite fiddly and tend to have quite a few sort of complications in terms of things not working. So they would be really, really great when you're doing adhesive dentistry, but I don't have access to them. So yeah, but they would be great.
Okay. There's a broad question here. What's the best approach in managing white opaque lesions in children? Is it specific or case selective?
Yeah, I think it depends on what the origin of the lesion is. But I think Icon is becoming a really, really good option for it. As I said, I've had limited experience with Icon. I've seen a lot of cases and it looks amazing, but I haven't been able to get any yet. So that's something I'd like to explore.
Okay. There's a question on preferred. I think we'll give the questions maybe 5 more minutes because maybe we're running out of time, but we'll rush things through. Preformed composite crowns versus stainless steel crowns. What's your experience? Perhaps maybe
do they mean preformed zirconia crowns?
Yeah, maybe you can lump them. Maybe preformed composite crowns, maybe zirconia crowns versus stainless steel crowns.
So
Any experience?
In my experience, yes. In my experience, I've had limited experience with zirconia crowns, and in my experience, I just find them extremely destructive, especially when I'm a minimally invasive orientated dentist. I hate the thought of really drilling a tooth down to a stump to be able to put a crown on it. I think they're a really good option where you have already carried out pulp therapy, and I've seen some cases where you tend not to get biofilm forming on the surface as much as you do with even stainless steel crowns. So in that respect, they look amazing. They're really good for biofilm prevention, but I just find them very, very destructive. And honestly, stainless steel crowns are so simple and effective. I haven't felt the need to start zirconia crowns, but I think there definitely is a certain type of parent who will not consent to having metal in their mouth. So in that case, you may have to.
Okay. Oral hygiene is not given a lot of prominence as behavior management in pediatric dentistry. Can you comment?
Yeah, I mean, I think oral hygiene is so important. You know, that the balance between the diet and the brushing and the effectiveness of the brushing, how often we're brushing, when we're brushing. Sometimes I find there isn't even a consensus on that. So it's I think oral hygiene is extremely important. Even things like flossing, you know, it is important to start these things early and to try and make them habitual so that patients are not thinking about it. It just happens automatically. And I think that would be a real win. And fluoride. the amount of fluoride that we need to use for different age groups, making sure that they're using a fluoride toothpaste, because some patients aren't, and we have overwhelming evidence for fluoride. So I think that's something that's important.
Okay, I think in your category of risk assessment, some of the high-risk patients are usually those who avoid regularly visiting the dentist. So what methods of motivation to honor their appointments or to have frequent recall visits, how do you motivate your patients to come and keep appointments and come for checkups?
So I think that that may be sort of a practice-based thing, but I think recalling the patient, if you have a patient who's got some difficulties and you know that they need to be seen early, then put them on a separate list that you are responsible for or your reception is responsible for. And every couple of weeks, look at that list and follow up. And I think now with this current situation, I feel like we're going to need to do this a little bit more, because at the moment we have very little to no contact with our patients. So I think we're going to need to find a way of being able to reach out to our patients, reminding them, you know, maybe even with a text message to say, have you brushed your teeth? So yeah, I think you just have to make a special effort and make coming to the dentist fun, especially for children, you know, make it an exciting experience, give them a reward. So it's not a chore. They want to come to the dentist. I think that's really important.
Okay. Second, again, now a question about TMJ problems. Is that a source of concern in the Hall's technique in children?
I've never found that it is, actually. I haven't looked into the evidence, to be honest, but I haven't found that it is. I guess my rationale would be, you know, you're doing it in a child where there is a developing dentition, there's constantly changes in the occlusion and things tend to settle down. So I'm not sure we can necessarily put it down to a high crown. It might be other things, but I've never come across that.
Okay. Because they usually have very good dental compensation. We get away a lot with kids in terms of high spots.
Yes.
The questions are still coming in. I think I'll probably pick the ones relevant to our topic. Is SDF a take-home application process?
No, I don't think it is. It's a medical device, and so I probably wouldn't give it to the patients to take with them. And as I said, it really stains badly, so you have to be extremely careful when you use it.
Okay. Oh, the question about Concepsis. Concepsis apparently is chlorhexidine. So they're asking about rinsing with chlorhexidine before application of either SDF or Biodentine. Is there a role of a chlorhexidine rinse? 2%?
So I know that it has something to do with some sort of inhibitor. I can't remember the exact name, but I've never really used it. So I don't know, it might be worth looking into the evidence with regards to it, but I tend not to. But there may be something out there that that we can look into.
Okay. In terms of fluorosis, can you compare the use of ICON and the use of microabrasion in the management of maybe mild fluorosis?
So I think the good thing with microabrasion, I think you're tending to lose tissue, whereas I think with ICON you're tending to reinforce the tissue. I don't think you can use ICON with very severe fluorosis, but you can use it with the fairly mild cases. So yeah.
Okay. Can you use SDF in pulpally involved teeth if there's a carious exposure?
No, I definitely would try not to, because you're going to end up, you're really going to end up aggravating the pulp, and you're going to end up with requiring pulp therapy. And that's sometimes a difficult one because, of course, sometimes it's difficult to gauge whether the pulp is reversibly involved or irreversibly involved. But I think that if you suspect, then try not to use SDF, because it can really flare the tooth up.
Okay, it's not a pulp capping agent.
No.
Okay, I think maybe I'll give you the last question. What do you recommend for very young kids with proximal caries in the upper incisors? Because composite is usually very difficult, and of course, due to lack of cooperation and maybe moisture control.
So what you can try is to try and strip in between the proximal lesions. That way you're just making it so much easier to maintain oral hygiene at home, because sometimes, you know, food gets stuck in, and even for parents, it's not so easy to remove. So if you can try and very minimally strip the proximal lesions, and I would say the other thing that you can do is strip crowns. They're minimally invasive. They don't wear as well as zirconia crowns, but they're definitely a good option. So it depends on the age of the child. If they're really young, then I would just start with stripping and lots of fluoride. If they agree, then SDF, but if not, then fluoride varnish. And if they're a little bit older and they can sit through it, then some strip crowns would be a good option.
Okay. Is there a Hall's technique equivalent for the anterior teeth?
Yeah, I guess strip crowns would be something similar. So strip crowns is essentially it's like a plastic. So instead of having it as a metallic preformed, you're having it as a plastic preformed thing, and you just get the correct size. Again, they come in a kit, and so you just get the correct fit, and then you just fill it up with composite. You can even use a glass ionomer, and you just have to push it into the tooth, and that can work really well, because you're going to get this three-dimensional coverage over the tooth.
Okay. All right. Thank you very much. I think we should invite you again for another webinar. For any questions that have remained unanswered, kindly, you can always send us an email and we'll always get back to you. Thank you very much, Dr. Aisha, and the rest of the panelists and all the attendees. Yes, hopefully we'll have another webinar next week, and we shall be sending out the invites shortly. CPD points will also be emailed to each and every one of you within the next 2 to 3 days. All right, thank you. Have a good evening, everyone. Stay safe, isolated. All right, bye.